we're starting lunch hour, so we're going to have more people pop on. But why don't you go ahead and start out? I want to be conscious of everybody's schedules, and take it away, and to sort of cut back on time. When people ask questions, can you just identify yourself and who you work for as we go through the virtual roundtable here? But why don't you go ahead and start off, Jason?
And I'm going to share my screen so we can do this in real time too. You've got put stuff in the chat, questions throughout. That's fine. If you really want to raise your hand, we can probably attend to that as well. But I don't think this is going to take a tremendous amount of time just to go through this page, because it does have a lot of info, but it's really all there. So I want to leave as much time for questions, because I think really that's what people usually end up going to. You know that this site exists. You're gonna, people might be playing around with it while I'm playing around with it, and that's perfectly fine. Eventually, most people will go to that website, and hopefully they'll be able to now remember what those things are. So let me just get the link right now, and I'll put that in the chat, just so people have that too. And then I'm gonna share my screen. Sorry, I'm working on dual screens. A little tricky. Okay. All right, everybody, zoom down you guys. Everybody can see my screen okay, right?
Yeah, looks good.
All right, so this was the link that I just sent to. It's unfortunately, this is kind of buried. It's not, right when you go in. A lot of people are going to our main Hawaii COVID-19 page, right? This is where we want to steer more of this general traffic. You can see some of the table here is replicated. But to me, this always has more information than I need, right? Because it's got all this other stuff. It's, the scrolling marquee and whatnot. The whole source for this is really from our disease investigation branch webpage, which I navigate back to here. So it's the exact same information. I love this application Tableau. It just kind of replicates across all these different sites. So this just helps us kind of keep in check with and make sure all that data is being put out to the right places at the right time. They just started this nice cleaner table, really easy to understand, about how many case counts per day, what that change was from the previous day, and some other stuff. When you hover over, if you notice, gives me additional information. So we've had a lot of time to play with this and just make sure that we're adding more and more enhancements. So don't get overwhelmed. Lots of numbers here, lots of stuff to see when you're scrolling around, right? But should be very apparent. The main takeaway I want to say here is, again, when you're looking at, in public health, we can't just look at, that individual or specific day, right? That's, wow, 460 today. Whoa, that's a lot. True, but what does that mean in the long terms of things? And, certainly we're seeing things about, around different islands. And in terms of interpreting this information, there's far more sophisticated ways to kind of deal with that rather than looking at a pure case count per day. So the takeaway from, I'd like you to take away from this table is that, yes, we're going to be seeing cases every single day. There is community transmission. This is a very virulent strain of COVID-19 we're seeing right now, and it's moving very efficiently through the unvaccinated population. When we go down here, this is the kind of main summary metric. Most of my conversation today will be based on particularly this table. It gives you little snapshots altogether from each county and a statewide one going on here too. One thing to note is that we're not talking about daily numbers anymore. And whereas this one was giving you that kind of shock value that you see, like 460 cases today, be aware. This one is trying to smooth it out, and I wish people would pay a lot more attention to this, because this takes into the dimensions of time and a whole lot of other things to give you a better sense of where we are and what's going on. And so we have been averaging 110 cases. This is over a 14-day, I believe, category. So not only did we have a large amount, but this has been sustained for some time. I would say about 4 5 weeks ago, we were probably in the 20s and 30s. And that's just exactly how explosive the Delta variant has been. The test positivity rate here is saying, you know, just taking if I got 100 people taking a test, what percent of those are coming back? And for whatever convention, this is only for the past 7 days, and that's, you know, just, you know, that's not really that necessary to say, but we are still seeing a high level of test positivity. But in comparison, there are places in other jurisdictions in the US that are far exceed that in the 30s, 40s, and even higher. The WHO put a standard that, you know, really countries, cities, states, you name it, shouldn't be opening up until that test positivity has decreased to 5% and below. That means there's always going to be a background of COVID in our environments, but when we're at this rate, test positivity is high. And, you know, we are only seeing really the tip of the iceberg in terms of this. Since I can't, you know, magically test every 200,000 people on island plus the potential 30,000 tourists we have on island historically per day, we're only going to know this test positivity and number of cases by those accessing testing. So that's why having access to testing in many locations, some at no cost, is really a good strategy to knowing what's going on. But am I to say there's only today, you know, 84 people newly reported to DOH? That's true, but could there be a lot more than 84 newly sick people or who just found out that they were positive? Absolutely. And so it's not an absolute number. There's a whole lot of activity going on island. This test positivity rate is going to change through time, and it gives us a better sense of what the denominator of people that are seeking testing are coming back with a positive result. And of course, our completed vaccination, that's 58%, because that's our total population. So it includes those that are 12 and under that are even eligible to get vaccinated at this time. So those are kind of why some people say, I thought we were over 70, or aren't we a lot higher than that? It's like, yes, it is, but there's some reasons why. So you can kind of compare the counties going on here. What's interesting is if we go back to August 2nd here, where our case average was 81, now we're at 109 for that, you know, our new case 7-day average. These things, what we're seeing here, and this percentage really should be what we're looking at. So when we're having only, you know, 15, 20 cases a day, the first couple of days after the variant really started to be detecting and ravaging through our community, we were getting what you're seeing on Kauai right now. So a 250% type of increase, you know, from what that number of cases, what the average cases a day were 7 days ago. So what appears now is that we may be hitting a ceiling limit for our testing capability, where we're averaging over 1,300 tests a week in the last 7 days, which is, you know, a really good increase from efforts before. But we're also seeing, you know, our test positivity reached up to 8% at one point, and then it's now starting to come down. So that doesn't mean there's less people sick. Our volume of cases is still high, but those accessing testing overall, that test positivity rate is not going through the roof too. We're not seeing 30-40% of people seeking testing coming back positive. So there's still a lot of people, for whatever reason, seeking testing. Maybe they're symptomatic, maybe they're not, maybe they've been exposed, maybe they've got you know, a surgery or a travel or work-related issue to get tested. So we're getting a better sense of what's really out there as our test volume increases. But the important takeaway too here is that this 35% means, you know, we're not seeing, you know, an exponential growth of cases that we were observing some time ago. This curve on Kauai is really where, you know, notwithstanding the numbers, because Kauai is much smaller, but the same kind of curve, it's exactly what we saw if this would extend beyond August 2nd and prior. So it's kind of smoothing out, but that might be, you know, certainly because people are taking preventive action, people are getting vaccinated, which we are seeing more people getting vaccinated, but we also may be seeing a limit of those truly accessing testing. We can't force people to get tested. Like I said, I know there's a lot of info here. I encourage you to play around. I'm going to go through some of these as well and then scroll down on this page just to see some, but I wanted to spend as much time as possible on that. So forgive me if I I went far too much on that. In terms of testing, we have a map here on where those cases are in the past 14 days. Not surprisingly, our highly densely populated areas are going to account for, you know, a higher volume. If we did this per incidence, you know, per population actually there, we might get a slightly different map. So make sure that you're kind of, you know, looking at your denominator here when you're taking on these things. If I, for instance, click on this Hawaii data, it'll bring this up. I can hover over and it tells me how many cases in the past 14 days, 372 people. I'm like, wow, that's a lot. But some of these other zip codes may have a smaller population in general, and therefore the incidence is much higher. So, you know, those are things to kind of take into account. Another thing I'd have you look over is our epi curve. And so an epi curve kind of really is just a date on the bottom, number of cases on your y-axis here. And it just kind of gives you an idea of where we are going. And so this goes all the way back to November, October 4th, 2020, right? As you can see, just through time, we are not only at a highest peak recorded yet on Big Island in this time, but we're also seeing just this sustained for a longer period too. So what we expect fully is, you know, this number very well could be continuing to increase, but this is where those cases per day is going to determine the peak. And eventually a lot of epi curves, if I go back to, you know, our state data, I'm sorry, actually, this is all these state data, actually, I apologize. If we go back to just Hawaii County in general, we're seeing kind of these small little trends and peaks. But again, this is the highest that we've been seeing on Hawaii Island. County rates are a little bit helpful, more important to understand, because then it takes into that percent population. So as you can see, our state average is 46.4, but we've technically got the highest per capita. And that's just how alarming our numbers on the Big Island are right now. So if I take off some of these filters and put only, you know, the state, us, and Honolulu, we're going to see that this, you know, the Honolulu one matches almost the state averages in terms of average new cases for the last 7 days, but Hawaii is pulling it higher. We are higher per capita, but we're not able to really influence the state because, you know, we're just a, you know, a portion of the population. So disease activity is very high on our island. This last segment I want to show you is our testing page. And again, you can filter by counties. We were able to increase, we had a recommendation from our DIB to increase our testing by 25% in the community, and that was set at 1,200. So we are at the point through much of the hard work of providers on island and pharmacies that we're seeing a lot more testing on island. And that means we're going to get a better result of what this true percent positive is. And so we did peak at, you know, this 8%. You can kind of see testing started, you know, these gray bars on the bottom, just this volume of testing. This graph is the percent positive. But as the testing started to kind of wane, and this is when county was only getting, you know, 30 people per day when they'd sit out there at Hilo Civic for 5 hours. Now we're getting, you know, 400 to 500 people in that same time period, and we're sending people home. So we've been able to step up volume in terms of testing sites and testing access. We're seeing more positivity, partly because of the Delta variant. And a lot of these are in the unvaccinated population. Unfortunately, I don't have the data public facing right now that really speaks about, you know, whether it's breakthrough cases or what proportion are vaccinated. We're hoping to get that out soon. Elsewhere on this page, you'll see stuff about vaccination, same kind of thing. You can go down by county and maps. There's an, you know, we got a proper epi curve, I think is, here are some things that talk about travelers versus non-travelers. And not surprisingly, it's not our travelers. They may be bringing it in, but unless they're getting tested in Hawaii, we're not be able to put them in isolation quarantine. A lot of our cases are travel associated residents traveling to the mainland, coming back. They might be doing their safe travels requirements, and then they're becoming symptomatic upon return, getting tested, and starting their process now. stuff on mortality, specifics about age and race and whatnot. Some metrics about our case investigations. You can kind of see we're starting to get less people being able to be reached when we're doing our contact tracing. And even when we go a little bit further, here it is. We're having some of the reason why that they're not being tested. Here we go. And this is only for Oahu, but there's no reason to think that this may not be happening here. This kind of light blue one here, 12% are being refusing interview, and 49% are not even answering our calls. And these are, this is the people that we weren't able to get a hold of. So of the amount of, all the people that we weren't able to get a hold of on Oahu, more than half of them were because they just would not answer the call. 12% answered the call and they said, nope, not talking to you. And sometimes we're just getting poor data at phone numbers. So we got that going on. There's a whole bunch of other statistics. I just want to scroll to the bottom really quickly and let you know we also do a variant report, which clearly identifies that Delta has been in our community for some time. We do a bi-weekly cluster report, and eventually our breakthrough report will end down here too. One more thing I want to show, the HIEMA site also has additional metrics that aren't necessarily included there. The reason why I wanted to show you this data, and I'll throw this link into the chat a little later too, but we're at the point where it's not just about cases and what does all these cases mean for us. And unfortunately, one of the most glaring thing is really based on our hospital. And for those of you that have connections with those facilities, you know that they've never been busier. There is a whole lot of concerns about elective surgeries maybe being canceled, preventive screening not being conducted because people aren't going. And though we do have a hurricane out in the Pacific right now, all data says right now it might be going a little bit north of the state. But if we were to get hit by a large environmental disaster or some other mass casualty event, or even just a big car pileup, this could really impact us locally in terms of medical facilities, just in terms of how much people they have in house. So there is this hospitalization being reported publicly on the HIEMA site. We talk about ICU beds. Our island only has 24 ICU beds. Of that right now, 20% are in use, and eight of those are with COVID-19 patients. These are the kind of things that I'm really worried about. I see the fatigue in our healthcare workers. I see that some concern. And this is where all those non-pharmaceutical interventions, your masking, social distancing, any policies the mayor or governor is putting out are going to have ramifications on pushing this down. A vaccine is also a very good solution we are pushing out. It's not the one-all end-all, but it is that one that is most passive. You get your shot, you're fully vaccinated, and that protection is always up. And so far, the data for the 3 vaccines we have available in the US, whether it's Moderna, Pfizer, or J&J, if you can find a J&J shot today, it's fairly limited quantities. You are going to have a higher chance of survival. If you get sick, you're going to be protected from even getting the disease. And there's overwhelming evidence now that you won't get led to severe disease or death. These vaccines are not 100% effective, but they are very effective as they were designed. And so obviously, hopefully I'm preaching to the choir here about encouraging vaccination. With current vaccine requirements in place, this is stirring up a whole nother pot. And we are seeing a level of protests and refusal in many communities across the island too. And so this is going to add a whole nother dimension to our future too. So I know I probably talked too much already. It's 12:24. I did want to make sure I have enough information to kind of get this conversation started. I do think that employers like you can certainly assist in being prepared at your workplace. If you get a COVID case there, I can go through some of the steps on how we would conduct that. That's always, for your group, really a good thing. We can also talk about, what prevention steps you might be able to implement today to reduce that likelihood of something negative happening. And also make sure you have my contact info in case you guys want to take something offline or concern. I got my phone connected to me most of the time, weekends included. If you've got some urgent matter or an employee just said I'm sick and I'm at work and know if they have gotten sick, I can kind of help to peel back those layers as well. There's a whole lot of information at the Hawaii COVID-19 page, but then also a whole bunch of information for employers on the general CDC page. So I'll drop that into the chat too, just because there's so much information that's not on our local page. So, but other than that, I just want to make sure that you guys have this information. You get some of that forecasting, for you to know where to go and how to access that information and a little bit how to interpret it. And then also just what steps we can do to help you plan and mitigate in your households or work. So this chat.
Thanks, Jason. Let me open up for questions from the group.
Hey, Jason. Hello.
Hi.
Regarding the breakthrough cases, do you have any information which of the vaccines are holding up the best? Which, which ones seem to be susceptible to breakthroughs?
That's a great question. I think this is why I think public health is taking a very nuanced approach into how this information is shared. We don't want people to know that, well, I know so-and-so and the vaccine didn't work, so I didn't go and get vaccinated. There's a whole lot of things that go into saying a vaccine is effective or not. When Operation Warp Speed first started, they said in order for us to do an emergency use authorization for a vaccine, it's got to be at least, I think, 50% effective. When Pfizer was the first out of the gate, their early studies already had it pushing up to 70-80% with the first one, I think, or 87 and up to 93 with the second shot. These were with a smaller cohort. I think it was only about 30,000 people, the first studies when they applied for that EUA. And those metrics were pretty similar to Moderna. J&J as the one shot did not have a higher prevention rate, but it still succeeded in reducing morbidity and mortality. How they're holding up for breakthroughs is a little bit more challenging to describe, right? We're getting real time, and I'm hoping some of that data allows people to see it. But what also needs to be taken into account is that Pfizer was the first one on the market in mid-December. Moderna came about 2 or 3 weeks later. J&J came out months later, but then got put on pause because of transparency about what could have been adverse reactions, and that was confirmed. And so that got taken off market. As a result, less people started using J&J. So we can't always compare those three together because some people are taking Pfizer. If I'm 16-year-old, I can only take Pfizer. So it's hard to make that really firm idea of which vaccine is best or is best performing at this time. From a pure laboratory potential, the mRNA vaccines or Moderna and Pfizer seem to be really holding up well. And some of this data is also being replicated in other country studies or other lab results. So if I was to choose that one regard, I would probably stick with the mRNA vaccines. They seem to be performing even well with Delta variant. There's some lab tests that have been done, not in vitro, but in a lab that show that, they've been very effective in preventing illness by even the Delta variant. So I would say it's a little premature for us to go down that total route, but all vaccines in general that we have licensed in the US seem to be working well. And we're probably going to know in a couple more weeks or months, both in our state and nationally, just how effective these vaccines are.
So you think you will be releasing that information?
Yeah, we were hoping that the breakthrough data was going to be shared a little earlier, but like I said, we wanted to make sure that internally we knew how to message it, because you do have to take some of that account. We don't want people saying like, wow, that is not what I thought, and therefore it's not even worth getting a vaccine. I think the number I'm willing to put out, I think at this point, as I saw today, was I think it was 2% of cases since January 1st have been breakthrough. And if that is not enough for you to say any of the vaccines are working, overwhelmingly, then that should be enough. But as for what specific type, I don't have that information at this point to really go through. I think there's been over 1,000 breakthrough cases documented in the state. So even then, it may not be a good.
Yeah, but that's kind of what I'm getting at. Because if it's a breakthrough case, it means it's somebody who's been vaccinated, and they must have been questioned. So it's a simple matter to ask them, well, which vaccine did you get?
Right.
And release that information to the public.
And I believe that will be released in it. That's a fair metric, but it also has to be taken in what the volume is. I mean, most people in our state have gotten Pfizer. Then it's Moderna, and then it's really low for Johnson & Johnson because at a time, people wanted Johnson & Johnson. A couple weeks later, it was taken off market, and since then, not many people have wanted Johnson & Johnson. So by proportion of how much is administered and how much breakthrough, it's probably the better question. More people have gotten Pfizer. From a pure statistics, we're going to expect there's going to be more breakthrough numbers for Pfizer, but that doesn't mean it's less effective. There's just more people getting Pfizer.
Well, if the results match the projected effectiveness, then it would make sense. If the amount of Pfizer people were only 5% resulted in 5% breakthroughs, then that's what you would expect. But that's what we need to know. And
Right.
if all the breakthrough cases were people who took the J&J vaccine, then that's reassuring to the people who took the Pfizer and Moderna.
That's correct.
But we don't know.
Right. And
The only thing we hear is there's breakthrough cases.
right. And I think so as we accumulate more of that data, I think it's good to put that out. And I do think that's going to come out. But even with the information we have now, overwhelmingly, all vaccines are still preventing illness, and breakthroughs are still rare occurrences in the total volume administered. And so I do hope to have that information, and I can always send that when it goes live. I can always send it to Miles or someone to distribute. So we'll get that out to you. But I agree. We want to have that metric.
Thank you for your presentation.
Thank you.
Other questions?
Hi, Garth Yamanaka. I had a question. Any talk on vaccine for under 12?
We kind of expect Pfizer to apply for full FDA authorization by the end of the month. But that, of course, is only going to go to probably the 12 and older. Any other incursions in lower and lower ages, we're going to have to be through that emergency use authorization to make sure, right? Because we don't have enough data to go for full authorization. So I haven't seen any tentative date on that. I think everybody is anticipating it coming down. Those studies are ongoing, even down to the level of infants. And so that data is in current study. It's up to the manufacturer to then present it to FDA, and then a separate committee called ACIP reviews it. They make a recommendation, CDC makes a recommendation on that data, and then it's pushed out to the state. So we're gonna know probably when this is happening 2 to 3 weeks out after the manufacturer signals they're gonna apply for a new EUA for a new age group. So I don't think we have a date yet. I think we're all anticipating it, but it's largely going to be based on how robust these studies are from Pfizer, Moderna, or J&J. And just a heads up too, those studies are going to be ongoing for, I think it was 2 or 3 years. So when they started those studies early on during the COVID-19 pandemic. It's not something that they just did until they saw an effect and stopped. They're actually following people for safety and adding new age groups down the line. There's a question in the chat: what is the difference amongst FDA emergency authorization and full authorization approval? So all of our vaccines and all of our testing for COVID-19 are under what's called an emergency use authorization, meaning during a major disaster, the normal regulatory process of getting these things through regulation are thought to be a hurdle. And then the data being presented in the process is the bar is lowered. And so when Operation Warp Speed developed, vaccines to deal with COVID, they were able to do it much quicker. Number one, two, the mRNA vaccines in development are just an easier way to test, vaccines in general. So they knew that they would be able to create a product quicker, but then they had to still do human trials for safety and then apply for that. So even though they're not full authorization, they are under use authorization as long as the president still declares COVID-19 to be an emergency. And under that EUA, the provider has to tell you that it's under EUA. There's a fact sheet that accompanies that. There is safety data associated with that. And you and your provider can make that decision. Under full authorization, this is where any drug or medical device goes through full FDA authorization. And at this point, there's it's not related to necessarily any specific emergency, but they have enough data to say our product or our device or medication is safe enough to put out to market. And then individual providers can now go and buy it from the market. So for right now, if your PCP, small PCP in downtown Dela, is unlikely to have a COVID vaccine at their office because it's just not on full authorization. And in order for them to even give a COVID-19 vaccine, they would have to petition to the Department of Health because we're managing the inventory. And then we have to send it to them and they have to comply. Once it goes full authorization, the market then can keep it in inventory, and individual providers can now request that vaccine on market and then deliver it to their patients through their practice. So once we go to that full authorization, we may see individual providers out in the community being able to give it to you when you go to your annual physical or your medical appointment right now. If you're like me and you're a Kaiser member, Kaiser is already a provider with our vaccine program, so they have it. But your small private PCP practice may not have it. And that's really one of those full things. From a safety standpoint, they're going to have to submit information from a safety and effectiveness again for that full authorization, and it's going to be, of course, be reviewed by ASAP and all those other groups in order to go out. So it's just it's a parallel communication chain, but once it goes full authorization, it's not tagged to any emergency. Doesn't mean it's not safe or it's less safe. It's just it's tagged to an emergency declaration.
One more question.
Hey, go ahead.
Will antibody tests be available the way these regular tests are?
There are, and there already is antibody tests available. I think there even is an antibody. Don't quote me on this, but I want to say that there's a saliva, FDA-approved saliva test you can do at your home. There are COVID-19 test kits you can do at your home, and you send it to a central lab and get a result. The purpose of an antibody test, I think, though, is part of the challenge. Antibody tests aren't necessarily helpful in diagnosing acute illness. If you have presence of antibodies, it tells me that your body has antibodies for COVID-19. It doesn't tell me whether your symptoms that you have today are associated with COVID-19. We have different types of antibodies, and depending on if you were infected prior, that may wane over time. It may, have different levels. And so that's why we don't necessarily use antibody tests for acute diagnosis for many things. Not when we have a molecular method, which, that's that PCR method right now. If you go and you get a PCR test today, that tells us with a higher degree of validity if there is presence of viral MR or viral RNA associated with COVID-19 inside of you right now. An antibody test doesn't tell me whether you have virus detected in your body right now. It tells me that at some point you were exposed to COVID-19 enough to have your body produce antibody. And when
isn't that worth knowing? Because if you have the antibodies, that means you should be resistant, right?
it should, but we don't know how long that resistance lasts. So yeah, if anybody wants to go get a antibody test, by all means, I think you can request that from clinical labs. You might have to pay out of pocket. You might have to do things like that, on your own. It's not an acute diagnosis tool. There is also studies going on through the blood bank across the nation, a Sterile Prevalence study where they're looking at antibodies in blood tests. That gives us some information about just how it's spreading in general. Of course, that's a very specific population, that group that goes and gives blood, so it doesn't really tell us what the seroprevalence antibodies in our environment is. Either way, it's a tool, and there's a time and a place for that tool. It's not to be used for acute diagnosis differentiation.
Okay, thank you.
Hey, Jason, most of what's on your website, which I looked at this morning, is all current or past data. You must have access to future models to indicate duration of this surge and peak. Do you have any insight into what we can anticipate over the next month or two?
Sure. I'm going to see if I can. There is, obviously models, the one caveat with models, right?
Yeah.
Models are based on what we see right at the moment. And that's if to say, if nothing changed from today, this is what's going to happen. So models are very volatile. The reason why I put that caveat is that we don't have any modeling specific for Hawaii County or for the state because, we are one of 50 states and 5 territories, and this travel going between is really going to be hard to really put into perspective. So a lot of the models that I see come from, a national perspective. And the one model, there's several competing places that are doing this modeling. I found one site that actually takes a meta model. It takes like 15 models and sticks it all together and tries to find something out. When I last checked, and like I said, I'll try to find that link. I have it somewhere on my computer, but the most recent estimate nationally, they think for peak Delta variant activity is October 15th.
Okay.
Now, I'm not quite sure how accurate that it is today. I saw a news article from the LA Times this morning saying they're starting to plateau in terms of their new cases. There might be people, changing that whole model because they're getting vaccinated now, or maybe this is far more virulent than we really clearly understand, and therefore there's natural immunity starting to emerge in vaccinated populations that is going to plateau it. I would say you gotta just take those things with a caveat. It's not ending anytime soon. We're not at the peak right now. We only anticipate our case counts maintaining where they are, because I'm seeing no decrease at this time. So I don't know how high that peak is. I think it's not going to be as high as I was concerned a couple of weeks ago, but it's going to keep rising until we hit that critical maximum, and then it's going to come down. One of the maybe best indicators of what happened was in the UK. They had their Liberation Day, meaning all these rules and stuff got put up to the side right when Delta was hitting them. Things spiked up, and then 6 weeks later, it just dropped dramatically down. So if that's true, Delta has been in our population for far more than 6 weeks. It's hard to say what exactly our population is gonna deal with that. Technically, parts of the UK have a higher vaccination rate than even Hawaii County in our state. But nationally, we know that there are pockets like in the South where they're like 35% vaccinated. So there's huge swaths of the US population unvaccinated. That's just going to always do any kind of introduction that modeling isn't always going to be able to take into account. So I would, best estimates say that we are certainly not out of any kind of quick out right now. I just found the link. I'll put it into the chat. And it looks like for right now, like the nice thing I like about this particular model too. Let me share my screen again, just because there's a couple things going on here that I kind of want to explain as well. So if you're familiar with some models, they have what's called a sensitivity analysis here, where they make a couple of categories. One where a high vaccination rate is in a community, and at this point, it's on this model, it's 80%. And then a low variant transmission based on just the characteristics of the disease. So we have 4 different scenarios, one with low vaccine, low variant. The opposite is high vaccine, high variant transmission, and the other potentials. Because I'd say even in Hawaii County, we are not at that 80% vaccination rate. We fall into the category of low vaccination. And we know that what's turning out to be Delta is even true, that it's a highly virulent variant, and so we're probably in this scenario D. And so if I'm seeing that right now, I am looking that the model now is saying that our peak might be nationally. And reminder, this is the entire U.S. May be pushed back now to October 9th. And so again, I would say at this point, we are on a rise. There is no reason to think that we are dipping down at this phase or going astronomically up. We're still climbing that hill going up. And so, there are a whole bunch of models. They have all kinds of assumptions. I take that with a grain of salt. And if anything, for right now, there's no indication that we should be, slowing down any kind of non-pharmaceutical interventions or doing anything different. We should be continuing to push vaccination. We should be continuing to social distance, do these best practices. And the question is, how safely can we do this without affecting some of the bottom lines of employers like you guys, making sure that you have the workforce to do this and not getting, putting additional people at risk, but could be just a preventable scenario. I see another question here from Rich. What is the DOH guidance to someone who is found to be in close contact with a COVID positive person when that someone is vaccinated? And this is a really good question, because remember when I said COVID guidance is changing all the time? This guidance was actually changed probably about 2 weeks ago. And so for right now, when someone who is fully vaccinated, and by that definition of fully vaccinated, I mean 14 days out from either completing their 2-dose series or taking their first shot of Johnson & Johnson. So if it's 3 days later or 10 days later, we don't consider you fully vaccinated. You're treated like an unvaccinated individual. So if you meet that definition of fully vaccinated, and now you've been exposed to someone with COVID-19, at this time, we are not putting that person into quarantine or isolation, because there is overwhelming evidence that these vaccines work, and this person will majority of the time not get sick, not get ill, and not being able to transmit to others. Now, what changed the paradigm was that there was a large study released by the CDC where they found that, hey, even those that were fully vaccinated can still transmit. And so this is when all of a sudden things closed back up. Mask guidance for those vaccine nationally was changed to say, even if you're vaccinated, you still need to wear that mask. And what the guidance now is that if you've been exposed to COVID-19 and you're fully vaccinated, you should seek testing 3 to 5 days after that exposure if you're asymptomatic, because we may know by then what your status is with a higher degree of accuracy. So if you're going to become a breakthrough case, we want you to go get tested within that time frame, 3 to 5 days after that exposure. If at any time a vaccinated contact now becomes symptomatic, they should stop immediately what they're doing, go and get tested as soon as possible, and self-isolate until they've ruled out COVID-19 as a result of that illness. So that 3 to 5 day category of going and seeking testing is really what changed. If we were to say if every vaccinated individual that was exposed to someone still had to quarantine, obviously this would dissuade people from getting vaccinated. And also we know that a majority of the time, people that are vaccinated are gonna be okay. And they're not gonna die, they're not gonna end up sick, and a portion of them could end up being symptomatic or even asymptomatic and potentially even pass that on to others. But the likelihood of that is less risky than someone unvaccinated. So that's a policy change for right now. If that changes in the near future because we learn more about it, that's always a possibility. But for right now, a vaccinated contact does not have to quarantine or isolate. They can return to school, they can return to work as if nothing had happened, but they should continue to wear a mask like everybody else, and they should monitor their health like everybody else. And if they get sick, they should not go to work. I'm glad that came up. I've been getting a lot of questions from employers about that.
Thanks, Jason. That was clear. Thank you.
Jason, this is Miles. Got a question about the boosters. There's been a lot of talk, I noticed, especially this morning. Could you fill us in on that?
Sure. And so for right now, both of the mRNA vaccines, Pfizer and Moderna, for those that are immune compromised, they may seek what's called a supplemental shot at this time. We don't have a good way because a lot of our vaccine clinics that operated on the last several months, we're not that medical home for the individual. So we don't know if someone is compromised or else. They're going to have to attest for that when they come in, sign that on the consent form, and then do it. I think what people have to understand is that the medical sector itself is still on that premise of doing no harm. And though there may be no harm for majority of people, there is always a chance for an adverse event with any medical procedure. And so any widespread third booster recommendation for anyone that also comes with a potential cost. And so, for right now, the decision has been made by people certainly above my pay grade that for immune compromised people, seeking out that booster is important. If you got J&J, that possibility is not quite there yet. They're still kind of working on that, but like I said, due to a lot of inventory issues, it's hard to find a place that has a steady inventory of J&J right now. But for those that are immune compromised and may want to have that discussion with their primary provider, like, hey, I'm a cancer survivor, should I go get one? I urge you to have that discussion with your provider. For right now, we're not, requiring any documentation if you show up there. I would definitely inquire prior to going just to make sure. Like if you show up at a CVS and say, I'm here for my supplemental, and they say like, yeah, we're not doing those yet, or you need to fill this form out. I can't speak to what some of those pharmacies are doing. We're going to know a little bit in the next couple of days, probably through a medical advisory from our disease investigation branch, just about any more coordination for these people seeking a third or a supplemental shot would be. I'm not going to read through the whole definition. There is one on our website and the CDC about what constitutes a immune compromised person. It might be that you're HIV positive, you might be a cancer survivor. There are a whole lot of those things. But I think the important thing is when you go to a public vaccination clinic, they don't have your medical history. They don't know that you're compromised. So this might become one of those catch-22s where we just have to take your word for it and hope that that's in fact true. And some people may totally, break that system by lying, claiming that they are because they perceive that they want to get a third shot and they know inventory is available and they say, I don't care, I'm going to get it. I would definitely, if you fit into that category, I would definitely have those conversations with your PCP and then find a provider that's going to do that too.
Great, thank you.
So Jason, for kind of long range planning, I'm reading various articles about COVID being around for at least another couple of years in terms of how it impacts society. Is this sort of recurring tsunami of variants something that we should anticipate for at least a couple of years until the global population is sufficiently immunized? Or is there going to be a drop off in these surges, or what do you think we're looking at for the next couple of years in terms of COVID's impact and how we within our organizations should prepare for that?
And that's a fair question. I think the sobering thing for everybody in this kind of global pandemic is that COVID-19, for all intents and purposes, will become endemic. It may be like other coronaviruses that circulate globally, similar to influenza. I would remind everybody that when you look at the many names of COVID-19, technically there's SARS-CoV, there's also nCoV. That N standing for novel. And that's why we're at the stage where we are now. That novel is because first time in really ever detected in the human population. And because of that, the entire global population is susceptible. So that's kind of why there was so much fuss and why it's become the large thing that it is. Estimates of influenza can lead, in the last, I think, 10 or 15 years, the CDC estimates accounted for some 12 to 50,000 deaths of Americans per year. That's not something to scoff at when we have, a vaccine for that sometimes is more effective than others. And so what I anticipate is that because this is still a novel disease, right, and it's going to become endemic, eventually this could be something like what we're seeing with influenza, that it will lead to morbidity, it will lead to mortality every single year. How much we as a society are willing to accept that is going to be kind of changing over time. For right now, because we were all susceptible and natural immunity is so limited, whereas influenza, it's so widespread that even the variants don't really make much of a difference unless we have a super pathogenic kind of variant emerge. And so if you're not aware, the influenza vaccine changes year to year, or technically every 6 months, depending on where you live, because the different hemispheres review what's circulating in each hemisphere and then make a prediction about what's going to happen in the next hemisphere as the winter changes to summer and back. And so as a result, there's a gamble made every year by people above my pay grade about what to make our vaccine for, depending on that variant, and hopefully that it's effective. We may see something like that eventually with COVID-19. I'm not going to pretend to be a virologist and know that the vaccines that are working today are going to still be effective way down the road, or what that means for our vaccination. But eventually, COVID-19 will become endemic. It will cause morbidity and mortality across the world, and we as a society and a global population will have to decide where that breaking point is. How do we, encourage even routine influenza vaccination, but now we're also going to be routine coronavirus vaccination? And time will tell exactly where we are, but these extreme measures that government, employers, and individuals are having to make is largely because we don't have that full historical protection. And if we were back in January of 2020 and we just let this thing go because no one believed it, there would be a lot more than 600,000 Americans that have passed away as a result. Time will tell exactly which policies were effective and which ones were more extreme than they needed to be. And I think that's all within the realms of academia and public discourse. But if we had not taken any sort of action, we would have had a lot more mortality. And so, where we are currently right now, we have vaccines that are working. We have people that are taking those vaccinations. We have people who are complying and changing their abilities. But I do think that we all just have to kind of, at the in the long term get used to this. This doesn't mean that you have to wear a mask for the rest of your life. But for right now, if we don't, we're going to still see excess mortality and excess morbidity. And I'm not going to pretend to know when that all goes away. We may have country by country studies that we see the effects of these policies and what their mortality rates are. And each country is sovereign and will make those decisions. And unfortunately, we're going to have some case studies with probably death and morbidity to support some of this decision. So I know that's a hard decision and a hard thing for everybody to kind of get used to, but I am hopeful that we're going to get there eventually. I just have no timeline of when that is. And for right now, vaccinations, are a nice passive way that we can make sure that you're protected 100% of the time. And hopefully, it also reduces the variant coming in that then just takes all of our assumptions and throws it out the window again. So, vaccination also has that, from a pure biological and evolutional perspective, to really have a protection in terms of variants emerging that could have additional ramifications on our health. So, I know that was a long-winded answer, but I wish I could tell you, but we're probably going to be with this for a long time, but it doesn't necessarily mean that our policies won't shift.
Right.
In due time too.
It's the new normal.
I guess so. But it doesn't have to be doom and gloom either.
Right.
Humans are incredibly adaptable beings, and we're capable of great things. So I still have a lot of optimism and hope in my fellow brothers.
Hey, Jason,
Yeah, go ahead.
Jason, there's talk again about shutting down. Can you tell us more about that?
Yeah,
And
unfortunately, DOA.
If you have any input, with the governor, tell him that's a big mistake. Shouldn't do it.
Yeah,
Not fair. It's not fair. That's the main thing. But go ahead, please.
some of the best economic impact data was what happened with SARS in Southeast Asia. And the countries that were impacted and made decisions too early in defense of protection ended up having a longer rebound in economic activity. So again, I think DOH's standpoint is always that if things get to a critical limit, we as DOH or public health need to give policymakers the decision making and the data to support some of that. But it's always going to be based on if it gets to that point. If we can do other strategies that mitigate and slow this down, it will preserve some of our economic engine. But pulling that out too quick or too late is going to have different consequences. And so certainly, I get a lot more representation with the mayor and local civil defense. They are the ultimate policymakers, but even the mayor will now say that the governor, technically, if I make a new policy like airport testing, I've got to ask the governor to do that too. And at some point, the governors may be, having to deal with stuff being pushed down from the president as well. So we as DOH want to present all of this information so those that can make policies and execute them are doing so with informed choices. And I agree with you. If you pull out this economic and you put these hard restrictions down and you don't have a firm guidance on when it's going to open back up, it puts employers like you and your employees into a harder situation. And so, that's always in my mind, because things can get a lot worse than they are right now. But the question is, when do we as public health make those recommendations to make those stronger measurements? And I don't know if we're at that point right now, right? If we base it just on test positivity, we're a lot better than other places, and we've done our part to encourage vaccination. We've had majority of people in our community get vaccinated too. It's this other portion of the population that since we can't, push vaccines any more than we're currently doing, we're not going to get that additional level of protection. And so we're going to be stuck with kind of what's spreading in our communities, and then of course what's coming in from travelers and from our own residents going to Las Vegas, going to California, might be bringing something back. So there's something every individual can do, and I'll keep that in mind, Glenn. I certainly am very concerned about that, because I know, and I've had phone calls, I've had those discussions with many that are in that situation too.
It just wasn't fair that certain businesses were considered essential that sell the same stuff as some mom and pop store might. But one store gets to stay open and one has to shut down. It's not right. Thank you.
I want to be mindful of time. We're a little over 1 o'clock, so I've been here for an hour, and a couple of people have to punch out with other commitments. So mahalo, Jason, for a great presentation and set of questions. It's on, this is front and center for everybody in one way or another. It's fatiguing. So I was asking the long range questions. How long do we have to put up with this crap? Is my basic question. It sounds like a while.
Oh, yeah.
So anyway, appreciate it. And Miles will push out the video recording, which I'm sure will get the word out much more broadly through the chamber newsletter. And keep after it, Jason. We appreciate all the work you and everybody else is putting into this. The more info we have, the better the community can respond. And I really appreciate your willingness to take an hour and to help us out today.
No problem. Because this is really everybody's, we need everybody's help. That, this is why it's still very much important for DOH to handle requests like this. I'm glad we can do it in a virtual environment, and I'm not, talking to a room full of people like we used to do in the past. I put my email into the chat there. Certainly, if you want to have for detailed discussions or you want to pass along messages, that's fine. I do get a lot of emails. I try to make the time to get to each one, but I can't always do it in a timely fashion. So please don't hesitate to reach out. Your health, your employer's health, your families are all very important to me, because we are this community, and I need your support. I need your assistance in keeping your family and your workplace safe too. So it's very much worth my time. Thank you.
I appreciate it. Thanks, everybody. We'll have another speaker in a month or so, and after, so keep you posted.
Thank you,
Right.
Jason. We appreciate
Thank you.
all what you're doing, man.
Yep, totally.
Mahalo.
Thank you.
Thank you. Good information. Aloha.
Aloha.
Bye, everybody.
Bye, Mary.
Bye. Bye-bye. Now I can try to sign off.